Hello, all. Good afternoon. Please take a moment to review this first slide here and read some important information. So, welcome to the Deaf Hub Exploring Perspectives, DHEP. If you would like captioning, please click on the bottom menu, the CC square, to bring up captions. If you would like to ask a question during the presentation, please click on the Q&A button, again on the below menu, on the bottom menu. And at the end of Alex's presentation, he will answer your questions. The chat is disabled for this presentation. If you have questions, please use the Q&A button. This is live and unscripted, so what you see is from the heart. So first of all, hello, my name is Liz Ayers. I'm your host today and the facilitator for Q&A. I'm science and math faculty. I work in the Deaf Hub and I'm the director of the MSSP program. I'm also a sonographer. So welcome to Dr. Alexander Wilkins, Alex for short. Alex is a licensed clinical psychologist, assistant professor at UMass Chan Medical School. He's also co-director of Deaf Yes. That is a center for deaf empowerment and recovery. He will talk more about that in his presentation. Alex earned his PhD in 2019 and completed his master's degree in clinical investigation in 2025. Congratulations. He's a recipient of the K23 Career Development Award from the National Institute on Alcohol Abuse and Alcoholism, NIAAA, excuse me. Dr. Wilkins has specialized training in substance use disorders, as well as clinical research. His work centers on developing and adapting evidence-based treatment to meet the unique needs of deaf and hard of hearing individuals. He has a strong focus on community-engaged research approaches. Dr. Wilkins also provides comprehensive outpatient mental health and substance use treatment. He integrates innovative and culturally and linguistically accessible approaches for his deaf and hard of hearing clients. So without further ado, I will turn it over to Dr. Wilkins. The floor is yours.
Wonderful. Thank you so much for that wonderful introduction. It's an honor to be here. Today, I'll talk a little bit about both my personal journey, how I got to this point in my career, and I'll also talk about our Deaf Yes Center, the research that we do there, our values, and our mission and goals. So first of all, let's hop in a time machine and go all the way back to this picture, which is from the early 90s. This is me with my parents. I am an only child, and I'm the only deaf person in my family that I know of. My parents found out that I was deaf when I was about 10 months old. Now, this was before the universal newborn screening tests. And how they identified it is that my grandmother has 6 kids. So she is a very experienced mother herself. And when she was around me, she noticed that there was something about me that was different than other children in her experience. I wasn't really crying, I wasn't really responding to sounds. And so my parents took me to the audiologist, and the audiologist office said that I was fine, I was hearing, and they thought that it was just worried new parents overthinking it. So my parents brought me home, and then the phone rang, and it was the actual audiologist calling. And they apologized and said that that had been a student assessing me who was not allowed to work with newborns, who didn't know how to work with newborns or babies. And so they needed to bring me back. And that's when they found out that I'm deaf. My parents decided to teach me both spoken English and sign language to see what works best. My parents also learned sign language. Now, I was born in Wisconsin. My parents started learning sign language. And when I was about 18 months old, my dad got a job offer to move to San Jose, California, which is very close to Fremont, California. So they were wondering about the education opportunities for deaf kids. They found Fremont School for the Deaf there. And so when my parents moved, that's when they really got more involved in the deaf community. They started picking up more ASL. They learned more about deaf culture and everything along those lines, thanks to Fremont School for the Deaf. Now, my communication with my family is really mixed. I do use spoken language. I have some hearing. I got a cochlear implant when I was 20, and it's a useful tool. So my family also uses sign language. So we use a mix of both spoken and sign language at home. My education is really half and half mainstream and half deaf schools. So we moved to CSD, Fremont. And at that time, I mostly went to the deaf school, but I had some mainstream class. That's where I learned how to interact with hearing children, how to use interpreters, how to be in a mainstream classroom. When I was about 8 or 9 years old, we moved to Massachusetts. And there I was mainstreamed in a deaf program with other deaf students. So it was nice to have that interaction with both. But I also had ASL interpreters too. From there, we moved to Wisconsin. And again, I was mainstreamed. Sometimes I was the only deaf student, sometimes I was in a deaf program. And that's when I realized during that time that I really missed the social aspect. Mainstream education is great in a lot of ways, but for high school, it's really important to learn how to be a person, right? You're learning about your interests, you're learning about what is your motivation for the future. And I felt that being in a hearing public school was really limited. Wisconsin School for the Deaf is also very small, but I still had friends and contacts in California. So I made the decision with my parents' support to move back to Fremont and live with friends by myself away from my parents. And so I went to CSD for the last 3 years of high school and graduated from there. That was a very rich experience that helped me develop my interests and my hobbies. Here's a few more childhood pictures of me. So my title was driven by curiosity, right? And I want to touch on that here. I have always been very, very curious. I was a curious kid and fearless too. I wasn't afraid of the 100 ducks in the lake. I was happy to feed them. I would always ask for like science gifts. I always wanted to learn more. I loved books and museums. I loved learning, and I was very, very curious as a kid. So it really makes sense that I'm now in a research career. So for college, I decided to go to Gallaudet University. When I started in a biology major, but I ended up changing my major 4 or 5 different times, including psychology, government and political affairs, biology. I think I thought about sociology at one point. Everything seemed interesting to me, and I could see all of these different connections. But I ended up going back to biology because I felt like it was the best fit for me and for research. My original plan was to do something related to environmental science. I had a really cool opportunity during, I think it was after my junior year. I did an internship in Hawaii with a deaf graduate student who was out there at the time working on her master's in in an environmental field. So I applied and received the internship opportunity. And it was a wonderful experience for me to get to see what it's like to actually work in the field, to actually do that experiment out in the world. I also learned more about that deaf graduate student's barriers, successes, and future career. Her work was in sea turtle research. And so you can see these two pictures are from my internship there. We had a chance to attach radio frequency tags. You can see that on the top on turtles, and that would track where they went. So the deaf graduate students' research was focused on eating and swimming behaviors, where sea turtles go around the Hawaiian Islands where they live. And then I did an honors program at Gallaudet as well. And so my side project, my thesis for that, was about their swimming behavior. So I looked at sea turtles, how often they surface and dive, what their breathing pattern looks like, and everything along those lines. So it was a very cool introduction to research. And how they made it work for me was on the bottom right picture here. The radio signal, it went through the radio. So hearing people were wearing headphones and they would hear beeping, meaning that a turtle is surfacing. And then when the turtle dived, they would not hear beeping anymore. So what I did was use the sound level meter attached to the headphones. And that way, when it beeped, the sound level meter would tick over and I was able to see it visually. So that was the cool thing for me about working with a deaf person who was already on the team, is that we could work with these inventive solutions. So after talking with her and thinking about my career options, I also did a poster presentation with her at a sea turtle conference. That was about 1 year after I graduated. And with that support, after I graduated, I decided that I wanted to go into a biology career. And specifically, I was interested in conservation biology. So I graduated from Gallaudet, and I did not go right into a master's program. I wanted a little bit of time and I wanted to explore my options. So I worked part-time and I was still living in DC at that time. And I decided to apply to 2 programs. One was at the University of Wisconsin. That's where my parents were living at that time. And then the second one is at University of Maryland, College Park, which is near where I was living at the time. I reached out to the University of Wisconsin to do an informational interview with them first. I wanted to learn more about their program and see what my options are, who their mentors were that I might be working with. When I got there, I did let them know that I was deaf and needed an interpreter. They arranged interpreter services. I met with the director of the program, who was very nice. And then my second meeting was with one of the faculty, a potential mentor, who did research on wolves, which I thought was very cool. I was really interested in that. During that meeting, basically, he told me that I could not be on his research team because I'm deaf. And that was it. So now, being older and wiser, I would react differently. But at that time, I was 21 or 22 years old, and I was just floored by that. I didn't say anything. I didn't advocate for myself. I didn't respond to it at all. And that's the moment where I really started to realize what the reality would be for me if I went into a very hearing dominated field. I'm not saying it was the wrong decision, or it is a wrong decision for anyone, but that was the reality. And that's something that I had to decide at that point. So I applied to the University of Maryland. They had a dual program in public policy and conservation biology, and I had to apply for both programs. I applied for both, but was only accepted to public policy. And there I continued to have bad experiences. It's a very large graduate school, so classes had maybe 40 or 50 students at a time. I didn't feel like I was getting the support that I needed as a deaf person. The interpreters weren't great. Interpreting services wasn't great. I had a lot of really frustrating experiences, and I even failed a class. So I decided that was it. After 1 year, I left that program. I wanted to take some time to go back and reevaluate things. So I went back and worked part-time again at Gallaudet, explored my options, and I worked as an admin assistant for the English department at Gallaudet. While I was there, I had the opportunity to talk with different faculty members about their experiences in higher ed. What made them decide to work in a deaf environment versus a hearing environment? How did they make that decision, and so on? I happened to run into one of my old professors who was working for the Visual Language and Visual Learning Lab at Gallaudet, VL2. They do a lot of research and outreach, and they encouraged me to apply for an admin assistant job with that research center. So I did. And I also took a few classes on public admin. I knew that I wanted to do something along the lines with policy, information, outreach, research, something like that. But that was also a really big change for me because working there, I got to meet other deaf faculty, other deaf students who were doing research in a deaf environment with other deaf people. And they're sharing information and doing outreach in a way that's accessible to deaf people and really makes a change in deaf people's lives. From there, I thought that would be something that I could actually do in the future. And remember, one of my majors in undergrad was psychology. So it was sort of a full circle kind of thing. So with that, I decided to why not apply for the clinical psychology PhD program at Gallaudet. At first, I was on a waiting list, but eventually I was admitted. And it was a really great experience overall. The program itself is fully accessible in ASL. And then my clinical training experiences were a mix. So many of them were in hearing environments where I was working with hearing clients with an interpreter. But then some of my placements were also in deaf-centered areas. So I was able to work at a deaf addiction center in Baltimore, Maryland at the time too. And from those experiences, I was able to get a sense of a good balance between working in a hearing environment and a deaf environment. And I was able to identify which of those would be the right fit for me and what I wanted in the future. My thesis was about assessment practices for deaf and hard of hearing clients. And assessment here is referring to when psychologists give tests to people to figure out different things like their IQ, their emotional needs, their cognitive functioning, for example. And I'm sure that you can guess that many of those assessments for deaf people, for ASL users, are not that great. We have best practices and guidelines that we were taught in school, but then how those are actually applied in real life and what people are actually doing often looks different. So what's a basic level of training and learning that someone needs to be able to do a good job in administering those assessments? And again, that's coming from a framework of curiosity and wanting to learn more about what people are doing, and then also how that information can really make a difference in people's lives. In that PhD program, during the final year, we typically do, it's almost like medical school has residency after graduation. Similarly, in PhD, we had to do an internship for a full year after graduation, our final year before graduation. I decided to apply to a place that had some deaf services, not a fully deaf environment, but some deaf services. And I found a total of 7 options. I applied to all of those. I did all of the interviews. And finally, I was selected to come here in Massachusetts to Worcester, where there's both a state hospital with a deaf unit and an outpatient services division. So I thought that would be a good fit. I ended up matching, and I moved here in 2018 for the internship. I graduated from Gallaudet with my PhD in August of 2019, planning to walk in May of 2020. And of course, from that picture, you can tell that that didn't happen. So I never had a graduation. It was a weird time for me where I felt like, was I still a student? I was still in that transition period from finishing my PhD, doing a postdoc. So in this picture, I'm standing next to my mentor, boss, Melissa Anderson. She is the one who created the Deaf Yes Center in 2014, and I joined in 2019. So I started working here, and I knew during my internship that I wanted to stay here in Massachusetts. There's great services, really cool people who work here. So I told Melissa that I wanted to stay and basically asked, how can I stay? We talked about it, and I decided to apply for a diversity supplement, which is applicable for any grant under NIH. that can be, I think now there are 31 different institutes under NIH. So any grant through NIH can have a diversity supplement added onto it that supports a postdoc from an underrepresented community. That includes people with disabilities, people with minoritized racial identities, and people who came from poverty. Unfortunately, there are no more diversity grants because the administration's priorities are different these days, but it was a really great grant opportunity for me. I did my postdoc from 2019 to 2021 under Melissa's larger grant. And as part of that process, I applied for a K-23 career development grant under NIAAA, which is the National Institute on Alcohol Abuse and Addiction. The K-23 grant was designed for people who are early stage investigators, so early career in research. Now, in my PhD program, I did have research, but I had a stronger clinical training experience than research. With the K-23 grant, I was able to get more training specifically on how to do clinical investigation and how to do research in a clinical setting, how to do grant writing, how to do some of that more specialized research career training. And that's when I got my second master's in 2025. Once I became a faculty, I also got promoted to co-director of the Deaf Yes Center. So Melissa and I are now co-directors of the center together. So now I'll shift to talking a little bit more about my research at Deaf Yes. Our mission at Deaf Yes is to collaborate with deaf communities to develop innovative addiction and mental health resources that are designed for deaf ASL users. The reason for this mission is because we have seen in traditional academic research that often they don't meet deaf people's needs.
Traditionally, academic research is very siloed in nature. For example, as you can see on the visual, there are researchers who work alone or with their colleagues in a lab or in a research center. They don't really talk with the community members about their needs, their thoughts, their dreams. And then there are the clinicians who want more research, but aren't asked by researchers about what they need and what they would value. And then there's another group of stakeholders, maybe mental health professionals, association members, parents, state service providers. All of these different parts are not connected in any way to provide a good treatment for individuals. So I thought if they were connected, we could do better. And I think about the 90s, there was general research with underrepresented, marginalized groups. They were recognizing that the traditional academic research is not working. It is not supporting those group members' needs. So they started community engagement research. Now, that is a type of researcher in which the researcher works with community partners. For example, it could be people who are within that community, they're experts in mental health, or they are willing to collaborate within the research team. And it looks like different things. You can join the research team as a staff member. It could mean maybe you're a once-a-month consultant that's brought in. You could be a researcher who would be working on the pre-test, the interview, the recruitment of the people, the participants in the research, asking the community members what's missing, where are the gaps, what do they need, and then acquiring resources to support this community engaged research. So every individual has value and has strengths. Community engaged research makes sure that each person, their strengths are utilized well, and the research procedure goes on until they provide research information dissemination. So we need to prioritize what the community needs over academic dissemination of literature. So How does DEF use community-engaged research? There are a variety of different approaches. Community is definitely ensconced in our development process. We open information, we send that to everyone. There's a call for participants in research as well. When we develop our research questions, we think about our deaf community advisors. They are involved in developing those research questions. They set up focus groups. We check in with the community and make sure the questions we have truly pull the information that we want to get at. All of our research projects have something called deaf community advisors. That's a member of the deaf community who isn't involved heavily in research, but maybe has valuable lived experience and is interested in coming to work with us at our weekly team meetings. We get consistent, valuable feedback on our processes, and it really has made a big difference, and I will elaborate more on that in just a moment. Prior to starting a project, we would start focus groups, we would host interviews, and we would try to get as many perspectives from as many people as possible from the community. So when we develop materials for interventions and approaches for therapy, we get feedback from those individuals that are piloting that material. So that's the different myriad ways that we get feedback from our community. Secondly, we recognize that there's a lack of information and knowledge about research and how it's ongoing and how mental health and substance abuse addiction is impacting the deaf community. And there's a lack of access to resources. So our priority is to share information, provide free resources online. We will present, we will have community events, we will host outreach events as well. It's important to build trust within the deaf community because often deaf people have the experience of being part of research. Thank you, the researcher has benefited, and off you go without any benefit to the deaf community. So consistently, we need to give back and be very transparent about what our research is doing. We consistently communicate updates about the ongoing projects that we're doing. And lastly, we do have internship opportunities for people. We're trying to focus on deaf and hard of hearing students to intern with us. We have a fully accessible intern opportunity for deaf and hard of hearing students. So our first, oh no, this was our second, next year we'll have our second psychology intern student who is deaf and hard of hearing. So this program is growing very nicely. So this picture is kind of special because it was the team that we started for our medical accessibility video that we created. We won a grant in April, May of 2020. Originally, we planned to have a fully in-person team, but obviously, as you know, the pandemic changed many plans. So we sent out applications for deaf community advisors. We got an advisor. We wanted people to live in Massachusetts or within driving distance. So just in case we were back in person, we could get together without problems. So one of our members was going to be moving away from Massachusetts, and we thought, this person is a really great fit. So we decided to pivot our work and group meetings to a fully remote environment. So that means that our ability to collaborate across the United States and across the world is much more seamless, and that results in a rich result of different perspectives. This picture was 2022 or 2023. It was the first time the group got together in person. We've been working together for 3 years. It was a huge transition. There are 3 researchers that were a bit nervous, like, will the quality of my work be as good as it is online as it is in person? But the answer is like, yes, everyone did very well. So we talked about designing two different projects. These were part of our goals. Our movie that we made was to train medical providers on how to work with deaf and hard of hearing people. It's called Vital Signs. This movie was a labor of love. It took over 100 people. There were over 100 people were involved in this project in total. This was the second version of this film. The first version was more geared toward research processes and practices. We wanted to explain how researchers can make sure that they get full informed consent for participants who are deaf and hard of hearing. It was a training video, essentially. And that was made in 2015 or 2016, thereabouts. And we started learning that this video was useful for training medical providers and medical trainers, but it didn't quite fit because of the research approach. So we decided to make a second version of this video. So the first step, after we got our deaf advisor, we wanted to have focus groups. Our original plan was just to do a hearing research staff and deaf research staff group, hearing clinician and deaf clinician research group or focus group. And then our deaf advocate said, you know, you need to include deaf community members in this process. So we made some adjustments, and wow, it was such a rich experience because we did so. We saw that the deaf community was just screaming. They didn't care about the research. They wanted medical access and mental health and recovery access. So we had to look at our budget, and we realized we couldn't do a whole new video. So this is one of the challenging parts of community engaged research. You have to really navigate your priorities and spend your money wisely. So we decided to reach out to our program officer at NIT and this person was coordinating the grant, and we were to contact them if anything had changed with our plan. So we described our situation, talked about our original plan, and we explained the fact that the deaf community really wanted resources and not research and data. We were given permission to revamp our original plan, and then we kept working. We focused on what makes a good medical training video. The first feedback we received was we want to see different clinical settings, not just one setting. So we ended up showing a scene in the ER, a regular PCP appointment, a mental health therapy appointment, and a GI, gastrointestinal colonoscopy appointment. So the second bit of feedback was that we need to include a variety of deaf characters who have different characteristics, different race, different genders, deaf, deaf-blind, deaf people who speak, deaf people who only sign. So our crew was very diverse. Thirdly, we wanted a more serious, a sense of urgency in the ER portion of the movie. We wanted it to feel more like the pit, if you will. The fourth bit of feedback we got was that people wanted more concrete information, how to actually bring in an interpreter. Because a lot of people said, yes, I understand this information, but where do I find an interpreter in a hospital setting? What does that look like? If it's a private practice, how do I get an interpreter? There are a lot of different state agencies and things and details to be involved. So we took care of all of those concerns except for the 15 to 20 minutes. The film is 35 minutes long. There was too much information for us to cut it down. So we have different versions now that we use for those who work in the ER. Another version is used for general practitioners, and in that way, specializing video, we were able to cut down the time length of that video. So the intervention development process, we had over 100 people involved in this project. We had a director who was deaf, another videographer, a former interpreter who signed fluently. We had a script writing process that was very collaborative. We got feedback from our deaf advocate and our community members, from medical professionals, and from interpreters. We would take feedback from anyone within the group. And we also wanted to provide deaf actors an opportunity to be involved in this video. So we put a call out for, in the Northeastern area for actors who might want to work with us. And we got so many interesting applicants. It was really hard to pick. I just wanted to make up a few more roles so we can include more deaf actors in this film. So we originally wrote the script in English. Then that was translated to ASL to make sure that the script made sense in ASL prior to filming. Now next, I'll show you, these are some scenes from filming. Here at UMass, we have a simulation lab where medical students can get practice in treating and taking care of individuals in a hospital setting. So this is exactly what you see. That's the training lab. It looks just like a hospital room or an ER. So the two people sitting at the table on the bottom screen, those were our patients. They played a role in getting resources and access to psychological help over the weekend. So everyone really enjoyed working together. Oh, I'm sorry. The two people sitting at the table weren't patients. They were our clinical office. So we filmed them on the weekend. The interpreter misunderstood, and we wanted to use all the resources that we possibly could. Now we're going to show a short clip of the video.
Thank you, Ruby. They will call you shortly. Where? Oh, you can take a seat right over there. Oh, you're asking about the sign language interpreter. Video interpreter.
Good morning.
Luke?
Who are you seeing today?
I'm here to see Dr. Horch.
Are you here for an appointment today too?
No, just waiting.
Okay, you can have a seat and they'll call you shortly.
Okay, thanks.
Ruby? Ruby? No Ruby here today? Okay. Chris?
The patient's deaf. We called 911 through the texting app. I couldn't ask the appropriate questions in the ambulance, but he's obviously suffering from severe chest pain and he's in distress.
I feel bad. He keeps signing stuff. We just don't know what he's saying.
Got it. Thanks, guys. Let's get that interpreter thing.
On it.
Marcia, you was calling like 49535.
Where was that video interpreter thing? I thought it lived in this room.
Ultrasound borrowed it yesterday. I guess they never brought it back.
Can you tell me what happened? Is there pen and paper around here?
Yep, I got it. Here you go. Oh, found it.
Someone left it in the hallway.
And we have power.
Where's the menu on this thing? Oh, there it is.
Yes, soon, soon. Oh, let's get some pain meds on board, please.
Oh man, this thing is slow.
So we started all of the scenarios by showing what not to do. And then second, we show what you should do. So next, my second big project with my K-23 grant was on a therapeutic approach for people with substance and alcohol use disorders, meaning people who are addicted or who struggle with using drugs and alcohol. So there's one approach that's often been used with hearing people called motivational interviewing, motivational enhancement therapy. That helps people understand what their motivations are for change and basically what they want to do to change things. Because historically for AUD and SUD, interventions have been very punitive and focused on shaming patients, basically. But we want to recognize that this is a person's own life. They have to decide that they want to make that change, and shame won't help people make that change. So that's the goal, is to have a conversation with people about their thoughts and feelings. And there are different philosophies about the theory of how change works. There are different stages of change. So there are some assessments to help people understand themselves better. I'll show a brief video here with the idea behind motivational interviewing, motivational enhancement therapy. Now, this does have audio with some captions that are okay, but not perfect. So we'll also have the interpreter on the screen too.
Fundamentally, motivational interviewing involves a change in role, a change in how you think about what you're doing. You're not the expert there to fix the person. You don't have to make the person change. The truth is, in fact, that you can't make a person change. You don't have to be the one to come up with all the good ideas. A person with really good ideas is sitting across from you and may have better ideas than you do. It's not like a competitive sport. It's not like wrestling where you try to defeat and pin and outsmart and outwit the person. It's more like dancing together, moving together, adjusting your movements to the other person. Overall, motivational interviewing is not a directive approach. Neither is it just a following approach. Following is listening to the person and kind of going wherever they go. Motivational interviewing is in the middle, between those two, and we describe it as guiding. If you go to another country and you hire a guide, you don't expect the guide just to follow you around. That's not what you're looking for. Neither do you expect the guide to order you when you will arrive, when you will leave, what you want to see, what you will enjoy, what you're going to do. That's not a good guide either. Good guiding involves good listening, as well as using your own expertise. A good guide will find out where you want to go, what you're interested in, what you're hoping for on this journey, and then help you get there using his or her own expertise, enjoyably, safely, efficiently, perhaps. That's the guide's job. Not solely directing, not solely following. There's some of each in it, but it's a blend of those things. This may or may not be the way you've been thinking about your own work, but we invite you to try it out.
So this is a great approach that is very empowering, but I saw two major challenges with this for the deaf community. The first challenge is that deaf people have a long history of oppression in the medical field and mental health field. And they don't often experience that shared decision making, right? Where a provider asks, what do you want? The patient shares, and then they can come to an agreement together. This is from a hearing psychiatrist who works at a state hospital here in Massachusetts about their process of learning how to collaborate with deaf patients and how they may have to show and explain and empower the patients so that they can make decisions together. And that's a really important part of this intervention, is empowering and explaining that this process is for both of us. It's not for me to decide. And it's not necessarily that family members are involved. They can be if the patient wants them to be, but it's really patient-led. And this change to empowerment and decision-making approach is really important for the client too. This is the second problem. Many of the materials are very dry, very boring, very text heavy. And to be fair, this was first developed in the 90s, so there's a little bit of grace for that, but they are a little bit outdated. The content is good. The approach is maybe where it could use some work. So for my project, I focused on a few different parts. The first is that I did interviews to help me understand what people's experiences were with treatment, what their experiences were in giving treatment and in receiving treatment. What did you like? What did you not like? What was that process like for you? I used those interviews to also help guide people who could be involved in the development team. From there, we developed a prototype of the deaf MET. We made some changes, adapted the materials, added some things. And then recently we've started the third stage, and we're currently recruiting 30 deaf adults here in Massachusetts with high-risk behaviors or use of alcohol or substance use problems within the last month. From there, we'll do some testing and we'll get feedback from them, whether they like materials, what works, what doesn't work, what we should change. And then with the next grant, we'll be able to continue revising those materials to make it even better. For the interview, I did 15 interviews with people in recovery across 9 different states with diverse ages. So from around the middle 30s to late 60s, early 70s. And I also had people who had experienced from a week being sober to a month or 2 being sober, from a year or 2 of drug use to people who have used different drugs and had different lengths of time. So I made sure that it was a diverse group. I've also talked with professionals who work in deaf and hard of hearing recovery settings. So with peer recovery specialists, psychologists, with other staff who are involved in deaf spaces. And I'm realizing that I'm running out of time, so I'll focus here on the second, which is internal themes. That's what we really focused on and what I've focused on for my treatment. Many people struggle to accept their substance use disorder because they may have a very narrow view of what addiction actually looks like. People who are homeless, who are sleeping on the street, but actually addiction, substance use, alcohol use problems can affect people in many different ways. And so I think it's important to give people a better understanding, not necessarily that they have an addiction, but that they understand what addiction can look like in different ways that aren't just those stereotypical ways. So when people go to treatment places, they often feel that their mental health issues aren't addressed, that people don't understand their deaf identity or deaf culture. They don't know how to navigate those systems and barriers, and especially to focus on their own recovery without those outside influences. And then people also have prior experiences, prior trauma, prior experiences of growing up and being made to feel disempowered. So people may feel like they can't change their lives because other people often decide things for them, or they try to make changes, but people tell them they can't, or they don't feel empowered to be able to do that. So this intervention focuses on telling people that they can make change and they can do that and overcoming some of those barriers. Our main approach of what we did is develop the ASL vocabulary first. There are some things that don't have a common ASL vocabulary. So for example, motivational interviewing. The sign isn't motivational interview like an job interview. So instead, we use a sign that reflects that back and forth discussion that we have. We also restructured the treatment approach. So we added more time for relationship building. And then we also revised the materials to make ASL versions of everything and make the materials in text more visually accessible in the written English version. We also added 2 new components. One is recovery stories from deaf people, and the other is a value card sort activity. The main changes that we made to treatment were for the original treatment, typically you meet and you do the assessment right away. There's no time to build relationship between the provider and the patient, no time for the provider to get to know the patient at all. So instead, we set it up so that the first session is just time for them to have the conversation about what the patient's life looks like and why they're there to build that relationship. And then next, they can talk about the values of the patient, do the value card sort activity, and then not until later do they do the actual formal assessment. That way they can have time to build that relationship first. We also made it a little bit longer. It was formally 4 sessions, and we made it into 6 sessions. We also allow a support person as an optional thing. Obviously, there can be dynamics with communication and power and family dynamics, so we leave it up to the patient to decide if they want a support person there or not. We also revised the materials. If you remember the first really text-heavy slide that I showed about this, we made the materials more accessible with visuals and an ASL translation. Alcohol and you. What do you know about alcohol and how it affects your life and health? Do you wish you knew more information about alcohol? Do you ever wonder if you drink too much or if your drinking is affecting your life? Read on to learn more about alcohol, how it's talked about, and its effect on your mind and body. It's like when a doctor or pharmacist tells you about the effects of a medication. When you know the facts, you can make smarter choices. So that gives you an idea, and it's inviting a conversation, not just telling you what to do. The second thing we did is we filmed 5 people who were willing to share their recovery stories, and I'm sharing this here with permission. People often talk about not knowing other deaf role models, not knowing other deaf people who have gone through the same thing and who have gone through that challenging process of recovery. So we wanted to share some of these stories. So I would joke and say, that's how much I don't value myself. I didn't quit for myself. I would always say that I quit drinking when I was pregnant because of my child. I quit for my children, but not for myself. I didn't have any self-worth, and I was really missing that. But over time, as I became sober, I learned to love myself. And for the first year or 2, it was really, really difficult. I had a lot of trauma and emotions that I had suppressed, but now I learned to value myself. So to value herself more than ever is how that ends. But often we don't see real raw stories about the difficult process of recovery. So it's good to have these role models who can show people what recovery looks like. The last thing is that we made a value sort activity, value sort cards. I'll show you a quick example here. This is what they look like. So these are different things that people can value in their lives. And we have them sorted into piles of important and not important, with the goal of filtering from 70 to 80 cards total down to 5 to 10 top values in a person's life to help that person think about what is really important to them. And we translated that into an ASL version. And I'll show you this very quickly. So that's the definition, that's the term, and then we have the definition. And now we're also working on having a deaf artist make ASL physical cards too for that. And now we're doing pilot testing. I'll skip this slide and go to the last one. So my final thoughts in summary, my journey has been all over the place. It has not been linear, but I wouldn't have changed anything about it. All of those steps helped me get to where I am, and I learned lots of different things along the way that are important to me now, and I've enjoyed the process. Working in academia is very challenging in many different ways. There's a lot of pressure. It's a fairly small group of signing deaf people. I work on a team of only 4 people. Hopefully that will grow in the future. And I've realized that I have to get my non-negotiables met. So I have to work with strong allies, hearing people who will actually support me and who will fight for me when I'm not able to. I also don't want to deal with accessibility. I do have to deal with accessibility, but I want to have additional support for that. And I want my employer to be willing to pay for it. So it's important for you to know what you're worth as a deaf person, whether you're in the scientific field or in mental health, and know what you need. So I'll end it there. Thank you so much for listening to my presentation. Hope you enjoyed it.
Wow, that was a wonderful presentation. Just a fascinating journey you've had. Thank you for sharing that.